Good morning. Well, first of all, thank you for Dr. Fernando Carrillo's invitation to participate in these classes. I hope the information I'm going to provide is useful. I'm going to share here with you the chosen topic, ossification of the posterior longitudinal ligament, a condition whose main locations of cervical layer and lends itself a lot to debate about symptoms, clinical data, and of course also a little approaches and how to deal with these patients. By way of introduction, as its name indicates, the ossification of the posterior longitudinal ligament is precisely the calcification of this structure. We know that it is a ligament that runs along the back of the vertebral bodies, this from the axis to the sacrum, and although it's a little thinner than the anterior one that is on the counterpart of the vertebral bodies, it provides us with some resistance for a hyperflexion of the spine, slightly protects the propulsion of the intervertebral discs, and also has certain nociceptive endings that generate some pain. The pathology itself is more common, as I mentioned before, in the cervical spine. It is the one that will normally manifest the symptoms. And well, the pathogenesis is not clear. There is no standard treatment, hence the importance of reviewing this issue. There is a lot of discrepancy between which approach is best for these cases, and there are already certain guidelines that we also try to capture in this talk and leave a little more about this situation. Epidemiology. We know that it is a disease that normally occurs in the Asian population, yet the incidence is low, 2.4%, and in the rest of the globe, while the incidence is 0.16%. Men predominate with a ratio of 2 to 1, and symptoms normally appear between the 5th and 6th decade of life. There is some other data that we can provide. It is also sometimes associated with the disease known as DISH, with ankylosing spondylitis, and there is a study that provides also a fact of those curious data, where in patients with schizophrenia, speaking of Orientals, up to 20% have found findings compatible with this ossification. I think the most relevant data is that it is estimated that only these cases, which are already few, are diagnosed. As for the etiology, it is not clear, but we do know that genetics plays an important role. There is no well-understood pathogenesis, but there are similarities between what is found in these ossifications and osteoblasts. And there are different factors studied, some local in animals. Those that have herniations of the nuclei pulposus tend to develop a certain ossification of this structure, some hormonal. These issues in diabetics are not dependent. This genetic relationship has also been observed in patients with a high body mass index. Some have been studied, such as collagen and some BMPs that stimulate calcification or the change in structuring of this structure. And some also environmental ones, such as consumption of pickles, consumption of rice, long work days, night work, but in gnawing. Yes, at the end of the day, there is nothing conclusive. Histopathologically, it is a mixed ossification in the opposite laminar and bones are reported, a lamellar bone with mature conversion canals, in addition to a calcified fibrous cartilage. This normally begins at the lateral junction of the structure with the vertebral body, in the posterior part, goes from the lateral part towards the center, and then has a slow, but of course progressive behavior towards the head and tail to form calcifications. The invasion of the canal is different. Therefore, so are the symptoms they will present. In autopsies that have been performed, there is necrosis that affects both the white matter and the gray matter. And of course, this is also related to what the patient may present. Natural history is not yet well understood. It is variable and unpredictable. There are already long follow-ups of some cases, and the interesting thing here is that only 17% of initially asymptomatic patients will develop myelopathy. That is why it is supported, and there is data, although well established, that it is not advisable to perform prophylactic surgery. Later, we will talk about the surgical issue, its suggestions. As for the symptoms, normally the patient will arrive already presenting symptoms, unless it is a finding from a study that is being carried out for other reasons. Other reasons for consultation in other branches of medicine, even unless it is reported as a finding, the opinion may be sent to the column module. However, they normally arrive because there are already symptoms related to the spine, primarily the cervical spine. Initially, there is mild pain, discomfort, and clumsiness in the hands. These are usually the first signs, as well as sometimes concrete and numbness. In already severe cases, of course, the myelopathy picture will be carried out following a scale. This is not normally a rule, but can behave as a downward trend. When it affects the lower extremities, the first thing observed is gait disorders in our patients. The classification there are 4 types of this ossification. Type A is a continuous ossification of the structure. Type B is called segmental. It is actually in the part at the back of the vertebral bodies. Type C is the mixed one that associates the first two, and type D is a local one, and normally begins to ossify only behind some of the discs. Regarding imaging, radiography can usually be useful in late stages. In the early stages, we sometimes even know the limitations of the shoulder shadow and so on. The radiography technique itself is simply not going to be the most appropriate, but in late stages, the changes can already begin to be observed. Magnetic resonance imaging is useful to evaluate neurological compression, in addition to seeing some other situations that may be associated, for example, in ossification. Segmental, that in addition, there is no herniation that is also compromising our nervous structures. And also look for the famous T-shaped impaired-intensity as a poor prognostic factor. And this supports the compression time that our patient already has, whether it is its own ossification or multifactorial. The tomography, due to the very nature of the disease, will be the standard body. It's where we will be able to determine the degree of ossification, its location, the count, etc. So in this case, our tomography is always going to be the standard goal. As for treatment, this is where there is some discrepancy. It will be conservative until data on myelopathy is seen. We mentioned, if the patient is simply a discovery, there is no reason to initiate any type of treatment. And if the patient is only presenting the first symptoms, it can be managed with different medications. Initially, according to the wide range of symptoms, we also have a wide range of medication possibilities, from pure analgesics, anti-inflammatory, non-steroidal, opioids, steroids, anticonvulsants, even antidepressants. This is decided according to how the patient presents. In some cases, temporary immobilization is even indicated to achieve certain stability and comfort in the patient, of course, always also involving physical therapy. And surgical treatment is recommended as soon as there is evidence of myelopathy. That is, whenever the neurological and especially motor issue begins, it is recommended not to wait and take action on the matter. What there is some controversy is as to what is the best approach once we are going to decide on surgical treatment. Ultimately, we have a structure that can be released in 2 ways, both anterior and posterior. The previous approach has shown great benefits for neurological recovery. It is a more demanding surgery, but if it is indicated, it will have to be done. And here, be careful, what is recommended is a corpectomy without resection of the ossification. Structurally, histologically, ossification is in a very intimate relationship with the dural sac itself. So when removing this, it is usually or recommended to leave the ossified structure floating, as the risk of a hard injury increases, as well as increasing central neurological symptoms. The posterior approach is considered to have less risk of neurological injury, And of course here we have to assess the previous sagittal balance to assess which is the best technique. We normally have two options in these cases. We know that the posterior approach is normally determined as a better option when there are 3 levels affected, and in this pathology, there will generally be more than 3 levels affected. We have, on the one hand, laminectomy, which is not recommended to be done in isolation, but rather be accompanied by fusion. And on the other hand, we have laminoplasty. As for the advantages of laminoplasty, it is practically a not very demanding technique, which in a certain way also preserves some mobility and balance in the patient. But precisely, we depend on an adequate sagittal balance for it to be a candidate as such. It is not recommended when there is, for example, a lot of accompanying axial pain. We have to evaluate structures, frankly, as participants, as co-participants, in a symptomatology, in this case of cervical pain, for example, some next added facet and so on, that leaving this free would not bring much benefit. On the contrary, we could leave certain symptoms. In very severe cases, a double approach may be necessary, always recommending first doing a posterior release, so that this is a way of recalibrating a new posture to our neurological structures, and subsequently, in a safer way, complementing the anterior approach. There is no better way to support this information than a clinical case, and we are going to see how it is compatible with the information we have just presented. In this case, it is a male patient of 41 years old, which we said is normally in men when it presents, and he comes after 18 months of evolution. As start, he was at work and suddenly falls because he loses the strength in his left leg. His companions help him get back on his feet, and although he no longer feels that lack of strength, he has a decrease in sensitivity. He says that his limb continues to be asleep. This is how the same thing continues. 1 month later, right inguinal pain is added, that is, on the contralateral side. And although we said that it normally begins first in the upper extremities, notice how it is debuting with the lower extremities, typical of amylopathy and its variety. It then begins with right inguinal pain, that progressively radiates caudally until it reaches the sole and there is numbness. Then there are both limbs with sensory alterations. 5 months after his debut, he is already assisted with a cane due to insecurity while walking. By the 6th month, even with a walker, we already began to have clear motor problems, and when he goes to the consultation, that is 80 months after his abolition, he is already in a wheelchair, only achieving standing, assisted by his family and some steps. Assisted by them. You take the walker, but to be able to take a few steps with it, your family members also have to be there as support. In the last 2 months, there has also been numbness and decrease in the thoracic limbs with pain to touch and movement, and they help him eat his food. He practically describes feeling like stiff skin that bends and hurts with every movement. That is, if you have a very, very limited quality of life, not only due to function, but also due to the issue of your pain. During the physical examination, we already mentioned, any test hurts him. When we manipulate it, hyperesthesias are determined or hyperesthesias are observed without a dermatographic pattern. In the thoracic limbs, there is an inability to press, and in the pelvic limbs, there is a motor deficit, a proximal 4 out of 5. In the rest of the myotomes, known data of myelopathy, bilateral hyperreflexia, Babinski, clonus in the left pelvic limb, the latter and hypoesthesia are observed, without a specific generalized pattern. At this same end, we begin to classify him. In this case, I classify him as a Nuri 4. Since even though his family members participate, he still supports himself a little with the walker and takes some steps. On our Japanese Association scale, with its modifications, it gives us a score of 5. The symptoms have already been mentioned. It practically has alterations in all the patterns to be evaluated, except in bladder function. It is the only thing that is intact, our patient. He had been previously studied and had a neuraxis, all by MRI. In fact, to comment, he already had 2 options or 2 surgical proposals. One of them was anterior discoidectomies for a diagnosis of cervical hernias, and another proposal was also a microdiscoidectomy of L5S1, while a decompression of L5 for a diagnosis of hernia. I don't remember if the proposal was microscydectomy, even instrumental and fused. What is striking here is that when we look at the cervical discs, which was one of the suspicions, notice how the nuclei look practically normal, and the structure behind them is what is seen affecting our canal. Hence the main suspicion. This patient had never been asked for more than an MRI. We go to the basics and see how in a simple X-ray, we already see a calcified structure there inside our canal. What are we going to do then with practically the standard gold diagnosis, which is the tomography? This is a coronal section where we see no longer any significance. If you look at it, it's a mixed pattern. First, it is continuous and then segmental behind the posterior bodies. So we have here the most representative section of the coronal section and also of the sagittal section of the agitational sections. Wow. If we see level by level, we see how it has different behaviors in each of them. In the upper cervical spine to the lower cervical spine, its greatest compression there at the C level is where this structure, our canal, made the greatest invasion. So looking at our collage and synthesizing the case, male, 41 years old, 18 months with a progressive neurological deficit that led him to a neuric 4, MUA of 5 points. With these images, we have a clear calcification of our posterior longitudinal ligament. How do we act then in this patient? First, we studied the sagittal balance, already planning a surgery. The surgical criterion was more than clear in this patient, but practically his parameters are preserved here. More than the sagittal balance, more than this situation, I believe that what deserves is to carry out measurements or imaging criteria aimed at the technique and the pathology. In this case, we observe the line here that is drawn in the space between C2 and C7, the midpoints of the lines that cross them, and we see that in this case, our entire structure is prior to them, so we consider a positive line K. And in the case of the posterior spinous line, or Fiora line, we draw it from the base of the C2 spinous to the C7, and it's the range that we expect in amplitude when doing a posterior release. Thinking about performing a laminoplasty. This is a transsurgical image. In fact, it was chosen to do a laminoplasty. Thus, resolving this case, we fixed it with some mini plates in C3, C4, and C6. Why those levels? Because transoperatively, they were the best suited to place our plates and were sufficient to maintain the opening. The laminoplasty was done from C3 to C7, as they are normally done wide, which sometimes also allows us to complement there by taking some parts of the anterior part, of the lamina. From C2 to complement the decompression towards the top a little more. So this was what was chosen, although there are plates for this technique. In this case, if you look at them, being careful and knowing them, it was made with mini maxillofacial surgery plates that can be molded and be useful. And sometimes also, we contemplate the economic issue of our patient. These are his x-rays. Control and follow-up. This is 2 weeks later. He went to have his stitches removed. And we have an improvement at the expense of the fact that he already had less pain in his right extremities. The discomfort in the manipulation was resolved of his left thoracic limb, in addition to reporting greater proprioception and movement in the right. At this time, physical therapy and rehabilitation began, and he then went for a new checkup. At 4 weeks, he was already able to stand up without assistance and used a walker for safety. He had less difficulty eating. At 12 weeks, we have a new radiographic control where we close practically everything in order. Mostly intermittent, spontaneous relapses. The walking was already with a cane, In this case, he was monitored by his relatives, who only assisted him when he got up. They already stopped him. Foot, and he alone with his cane continued. The strength was recovered in all four extremities, an excellent evolution, successivity recovered, and he only reported hyperesthesia in the pelvic limbs. As for them, at 24 weeks, they were only limited in the thighs. He was with his therapists working on balance and education in walking, which he continued to feel insecure and was still assisted by the same with a cane. And finally, at 36 weeks, the walking with a cane, he was going, sure that it was just because of the greater feeling of that security it provides. He was already asymptomatic. He began to use stairs with handrails, and these are X-rays. The 36 weeks. Yes, there was more monitoring of him for reasons unrelated to his pathology, and he was practically already doing squats with Swedish bars, among other circumstances, practically recovering his life. On the Nuri scale, we had an improvement from 4 to 1. I left this out because he still said that he very occasionally felt something strange there in his thighs, so we put it there as some affectation, some sequel to the compression he had on his spinal cord. The scale improved quite a bit, from 5 to 14 points, which gives us a recovery rate of 75%. And what can we then conclude from this? The ossification of the posterior longitudinal ligament, the pathology treated, is a disease, as we have already seen, of low prevalence in the population, especially Western. So the cases detected must be documented for its dissemination and knowledge, since precisely its detection and timely treatment depends on the evolution of the patients. Although the evidence at the moment is still considered to be little regarding this pathology, the advances in it and the recommendations seem to have the correct orientation. It's all for me to once again thank the association, Dr. Fernando Carrillo, for the invitation and remain at your disposal for anything regarding this pathology and anything that can support you. Thanks a lot.